not fully, just looking at briefly the anatomy and physiology of the biliary tract so that you know what we're talking about. If you noticed on the calendar, there's 2 actual lectures happening today, so this won't go till 1:30-ish, and maybe even get done a few moments before. We'll see how it plays out, and then we'll take a brief break, and then Mrs. Martinez will take off with eating disorders lecture, which is the second part of today. All right, so I'll switch to the computer, and hopefully everything works today. All right, here we go. So when we're talking about the biliary system, we're talking about that part of the body that pertains to the production and storage of bile. So we're talking about the gallbladder, which is a pear-shaped organ that sits on the underside surface of the liver. It stores the bile. We're talking about the cystic duct that empties the gallbladder. We're talking about the hepatic duct that carries bile from the liver. And we're talking about the duct that they share together, we call the common bile duct, which carries it onto the small intestine or the duodenum. So I'm going to switch over to the document camera and show you a visual of what we just talked about. So when we're talking about the biliary system, this is the underside of the liver. This is the gallbladder itself. These 2 branches together form the hepatic duct. This is the cystic duct. And when they join together from this point all the way down to here is the common bile duct. And I'm going to show you one more duct. This is the pancreatic duct. It also joins that common bile duct just before it enters the duodenum or the small intestine. Now, this obviously has a cutaway. What this is your stomach sits right here. Okay, so when your stomach empties into the duodenum, just a short distance after that is where these ducts enter the small intestine. Now, why is that important? Because the things we're going to talk about today is a disruption in that flow of bile. So when we're talking about the physiology, bile itself is produced in the liver. If it's needed, it goes straight on down into the duodenum. So if you've had a high-fat meal and it stimulates the release of that bile, then it will be dumped just straight into the duodenum. If it's not needed, it's stored in the gallbladder until it is. So when there are fats that are in the chyme that enter the duodenum, then cholecystokinin, and remember, chyme is that gooey, liquidy chemistry, if you will, that comes out of the bottom end of your stomach. Okay, so when stomach acid has already begun the digestive process, chyme is what enters the duodenum. So when chyme that contains fat enters the duodenum, then cholecystokinin is released by the duodenum and stimulates that release of bile. It's released directly from the intestinal mucosa, and it causes the gallbladder to contract, causing bile to flow into the duodenum. And when the bile enters the duodenum, it emulsifies or helps to break down the fats in order that you can digest and use them. Remember, fats cannot be used until they become fatty acids. They have to be broken down into their smallest component. And it can only happen in the presence of bile. Gallbladder can only hold about 30 mils of bile, so about one of those medicine cups that you see in Skills Lab, that's about how much it can hold. But stored bile is often concentrated the longer it remains there. So today we're going to look at 3 common problems that we deal with the gallbladder system or the biliary system. They are cholecystitis, cholelithiasis, and choledocholithiasis. So the first one we want to talk about is cholelithiasis, or gallstones. And I've listed several risk factors there for you. And notice how the first 4 you could use. Oh my goodness! Give me just a second. Let me think of the right word. oh, I can't think of the right word. You can use it's not an acronym, it's it's like a mnemonic, it's not exactly a mnemonic, but it's referred to as the 4Fs. Whatever that is right now, I still have a foggy brain, I guess this afternoon for sure. But it represents female, 40, fat, and fertile. And those are the 4 most common risk factors for gallstones, okay? But fasting also is a F word, so I don't know why they don't provide that as the 5 Fs. Meaning that if we don't stimulate the gallbladder to empty from time to time, then as that bile gets more and more concentrated, it begins to sometimes form crystals, and those become those stones. So anytime a person has had a prolonged period of no oral intake or no fat intake, so like those who avoid, who are on extreme diets where there's no fat intake and they don't stimulate that. Somebody who's on TPN, total parenteral nutrition, would be another example. Basically, you are bypassing the system and causing that gallbladder to hold that bile long enough, it may propose a problem. And then somebody has a gastric bypass surgery. Again, you're talking about there's not a lot of volume that's going to stimulate that gallbladder to secrete and dump. And then hyperlipidemia is also a risk because of a lot of the gallstones that form are formed directly out of the components of bile, and cholesterol is one of those main components of bile. So the process we're not exactly sure of the process, but it's presumed that it begins with the bile being left too long in the gallbladder. We call that bile stasis. And it causes the composition of that bile to become more and more concentrated. And so that cholesterol becomes more and more supersaturated. And then it begins to crystallize or form those little stones. And they precipitate. And then when they begin to fuse together, they form something too large to pass through that cystic duct or too large to pass through the common bile duct. Now, what's interesting is that gallstones can be asymptomatic. A person can have them for months or even years. They don't feel or perceive anything as long as they remain in the gallbladder itself, and as long as there's still room for the gallbladder to contract without them interfering with that process. So a client may actually have gallstones and not be aware of it until they're diagnosed by accident when we do some other, maybe a CT of the abdomen for a different reason, and we discover that they are there. So what are some signs and symptoms that a client is experiencing cholelithiasis? Well, the most commonly known one is what we call biliary colic. It is a severe pain. It's caused by spasms of those ducts as they're trying to force the stones down through them. So trying to move those stones through that pathway is what causes that colic. Typically, it feels like it happens in the midline epigastric area, and it may radiate to their back, to their scapular area, or to their right shoulder, and sometimes even to their substernal area. So many times biliary colic has the appearance of being angina, has the appearance of being somebody having an MI rather than a gallbladder attack. Nausea and vomiting is common. They often have bloating, belching, and a lot of gas, a lot of flatus. And then they don't tolerate fatty foods. In other words, when they eat a fatty food, then what happens is it stimulates that gallbladder to contract, and that's when they experience this pain. So that's what we're talking about, intolerance of fatty foods, is it really hurts when they eat fried chicken or whatever. Sometimes clients, especially with chronic cholelithiasis, may have very vague symptoms, and they may not be able to link it to anything initially. And then sometimes they actually have tenderness in that right upper quadrant. So much so that if you palpate in that area, they will guard against it. In other words, they will want to move your hand or pull away from you when you palpate that area. Now that's not quite the same as Murphy's sign, which we will talk about in a few moments, but it's similar to that. Okay? So any questions about cholelithiasis? Okay? All right. Then let's go to cholecystitis. So cholecystitis, I think I started with Talkwell last time. Let's go with Enid. What does the ITIS suggest?
Inflammation.
Inflammation. And so chole being part of the biliary tract and cyst meaning a bladder, then it's inflammation of the gallbladder. It also may be acute or chronic in nature, so it may be asymptomatic for an extended period of time. As far as what develops, 90% of the time it is due to a gallstone or a cholelithiasis in that cystic duct, causing it not to be able to empty, the gallbladder to empty, and then cholecystitis sets in. 10% are unknown, but some are believed to be due to a bacteria called Helicobacter. And Helicobacter pylori is the full name. You'll learn more about that in Adult 2 when you talk about peptic ulcer disease, because it's also very common source of peptic ulcers or gastric ulcers. Okay, so how does this one occur? Well, something causes obstruction to that cystic duct, and it causes distension of the gallbladder. And then an inflammatory response occurs. And remember, inflammation always occurs, Stillwater, as a result of what? Tissue injury, right? So when that gallbladder is so distended that it's impairing blood flow to the gallbladder itself, then inflammation sets in. And so the gallbladder becomes edematous and gangrenous. Necrosis may occur, especially if there's bacteria to begin feeding upon the local tissue. And so especially if bacteria from the GI tract has found its way into the gallbladder as well. It can lead to an abscess forming in that area. It can lead to a perforated gallbladder where the infected contents would then spill out into the peritoneal cavity, and we would call that peritonitis. Or it can enter the bloodstream and it forms sepsis or septicemia, like we have talked about on more than one occasion. So what are some signs and symptoms? So we're going to look at first the acute ones, so acute cholecystitis. And so there is a pain in the same vicinity, okay? So often a very sharp pain. Typically it starts suddenly and it increases steadily and peaks in about 30 minutes of time. Okay, so it has what, if you're a musical person, it has what we call a crescendo effect. So it starts at one level and gradually increases over the 30-minute window of time. There's tenderness in that right upper quadrant and that epigastric area, or both. These people experience something called Murphy's sign. And Murphy's sign is simply when a primary care provider uses deep palpation under the right rib cage, so the right inferior portion of the ribs. They palpate very deeply and have the patient take a deep breath. If that gallbladder is enlarged and inflamed, as they take a deep breath, the liver and gallbladder will come down and feel that and touch that provider's fingers and will cause excruciating pain for that individual, okay? So that is called Murphy's sign, and it's very definitive. They too have nausea and vomiting. Many times, because of that inflammatory and possibly infectious process, they have a low-grade fever. Their lab work will show increased white blood cells and possibly increased liver enzymes. And we'll talk a little bit more about how that plays out with cholelithiasis here in a moment. But basically, it depends on how widespread the inflammation has occurred. And then I've listed the 4 liver enzymes there for you. Okay, I said that cholecystitis can be acute or it can be chronic, or what we call subclinical. So in this situation, their pain is similar, but it's less severe. So their signs and symptoms are similar, but their pain is less severe. Fever is not typically as high, and their white blood cell count is lower and may not even be elevated. Their signs and symptoms are much more vague. They have indigestion, they have heartburn, they have that fatty intolerance when they eat something delicious, and then they have flatus. Okay. Okay. So any questions about cholecystitis?
You have a question in Enid.
Okay, go ahead.
If the gallbladder is removed, can the person still have signs and symptoms of this?
Oh, very interesting. There is something referred to as a post-cholecystectomy syndrome. And your book has a paragraph or 2 that I'll refer you to read about it. And basically it's similar symptoms, but since there's not a gallbladder, it's not identical. In other words, it's more apt to be an obstruction or a stricture in that common bile duct that's causing it once the gallbladder itself is removed. Out on the prep work, I talked about a cholecystectomy. I talked about being open or closed. And I have to make sure that it was clear because I'm not sure it was. A cholecystectomy is only the removal of the gallbladder. You still have the hepatic duct, you still have the common bile duct. You still make bile and it does still enter the small intestine. It just has no storage depot. So you have bile being dumped at a continuous process from the liver down into the duodenum. Okay? So any obstruction in that pathway can produce these same kind of symptoms, even though the person has no gallbladder. That answer your question?
Yes.
Okay.
It's online.
All right, so choledocholithiasis is lithiasis being stone, chole meaning part of the biliary system. Doco is the shared pathway, so this is a stone in the common bile duct. Okay, so this is past the cystic duct and further down in that pathway that I showed you at the beginning. Basically, the etiology is the same, only this time the stone made it further down the pathway before it got stuck. And there is a narrowing of that common bile duct right before it enters the duodenum, right before it joins that pancreatic duct, where it's easy for it to lodge, if you will. So as far as signs and symptoms, basically, they're pretty much the same. The client may or may not be able to tell much difference, and it might not be easy to tell just from clinical presentation. The physician may know exactly that this is a biliary problem, but until we do the diagnostic work, he doesn't necessarily know where the stone is. If it's in the gallbladder, if it's in one of the ducts, or if it's in the common bile duct itself. Jaundice occurs because remember that the common bile duct is where the hepatic duct also has to empty. So when the hepatic duct is free to dump bile into that common bile duct, and then the gallbladder gets completely full, that begins to create congestion within that liver itself. And that congestion then begins to cause ruptured blood cells and jaundice. So the bilirubin that is part of that bile begins to get reabsorbed into the bloodstream at a faster rate than the kidneys can eliminate. And so you see that yellowing of their sclera of their eyes. You see the yellowing of their skin, and we call that jaundice. The white blood cell increases only if the common bile duct becomes inflamed, and we call that choleangitis. Because of that reabsorption of the bilirubin back into the bloodstream, there is an increased total bilirubin when we check that. And then we start seeing the increase in those liver enzymes, especially the ALP part of that. And so I've listed those increased liver enzymes. Amylase is the enzyme produced by the pancreas. Now, when Mrs. Haig talked about diabetes, she talked about how the pancreas has an endocrine function and an exocrine function. I think we're at Stillwater. Stillwater, what's the difference in those two functions? What does that mean? What is endocrine and what does exocrine refer to?
It goes into the body and acts just like leaving the body.
Okay, that's one way to conceptualize it, but in this context, it's not actually leaving the body.
Or leaving the system and out into the body.
It's leaving that system. Still not quite getting where I want you to go with that. Anybody else want to try to define that differently? Endocrine means the release of hormones is like when we talk about insulin and glucagon. Okay, so it's used within the body to regulate our metabolism, especially carbohydrates, but also of lipids as well. Exocrine, on the other hand, is a digestive purpose, meaning that the pancreas secretes digestive enzymes referred to as amylase, and it allows us, helps us digest complex carbohydrates in the small intestine. So carbohydrate metabolism begins in your mouth when you start salivating, but those are more simple carbohydrates. It's not until you get to the duodenum that we can break them down further to amylase. So if you have a cholelithiasis right there before the common bile duct enters the duodenum, then the pancreatic duct may also be obstructed, meaning that the amylase that's supposed to go into the duodenum gets backlogged into the pancreas and begins to digest the pancreas. So it produces a pancreatitis. If the liver is damaged, because the liver also produces clotting factors, then we often will see an elevated prothrombin time. It means they have a tendency to bleed more easily and more prolonged. So out of the preclinical work, I covered each of those diagnostics, and I provided a handout, so you have a handout of the same information in a different format. So you can refer to those. I'm going to bypass through all of these. I did pull them out because I want you to understand that ultrasound of the gallbladder is considered the screening diagnostic test initially used because we can see the soft tissues very well. The problem with the ultrasound is we can't see the bottom part of the common bile duct.
Your mic is on, I think.
Oh, yes. Thank you.
Oh,
so is ours.
So, yeah, anytime I ask our students a question so you guys can hear it, then I forget to turn it off, and I'm sorry. So the ultrasound does not allow us to see what is happening behind the pancreas and that duodenum, and so we need something else. The nuclear scan of the gallbladder, or that HIDA scan, is one example of how we can see behind that. And then the cholecystography, remember, uses X-ray, and it also uses contrast media that the patient consumes. And I think I gave you the wrong time frame on that slide. Those tablets, I think, are to be given an hour apart, not 5 minutes apart. I think I gave you a different time frame on the prep work that I gave you. Yeah. I believe that's what your diagnostic talks about. Now on the cholecystography, so that's the one where the patient is consuming the oral contrast, and you give each one with a glass of water about an hour apart. And then the cholangiography, remember, is the injection of dye into the bloodstream, angio meaning the blood vessels. And then the ERCP is more invasive. It's an endoscopic procedure. It can be used to find, but also to remove those stones in the distal end of that common bile duct. So somebody who is suspected of having choledocholithiasis, because their ultrasound of the gallbladder shows engorgement but no stones visible, then the ERCP can be used to go in after them, not just to diagnose the problem. Okay, and I also discussed each of those labs out on the prep board, so we can zip past that one for you as well.
You have to go up a little bit.
Okay, so let's look at some medications. How are we going to address this as a healthcare
Now we're
team?
there.
Well, we do have what we call cholesterol dissolving agents. We don't see them being used much anymore. The gold standard is now to just simply remove the gallbladder. Maybe similar in nature, maybe not to the same extent. It's often viewed as expendable, like our appendix is, because we've discovered people can live without them, and many times if the stones are dissolved by one of these agents, they will return later, and so they'll redevelop. But basically, it reduces the amount of cholesterol in the bile, and it helps remove the risk of them forming larger and larger stones. But the stones can reoccur once the client is no longer taking those medications. And unfortunately, the original prescription time is indefinite. In other words, we don't know how long it will take to be effective for that individual. We also have the lipid-lowering agents, or the statin meds. And I give you an example. Simvastatin is an example of those. Basically, because cholesterol is a component of bile, then they decrease the liver's production of cholesterol, and as a result, help reduce the risk of stones forming as a result of that. And then we have something we call bile acid sequestrants. And that's kind of a scary kind of word, isn't it? It sounds scary to me anyways. Basically what happens is our body is very efficient in its use of things. So the bilirubin and things that are in the bile, when it goes down into the duodenum and is used to break down lipids, then certain components of that is reabsorbed into the bloodstream and sent back to the liver to be used a second time or a third time or however many times it chooses to. It is indeed a form of biological recycling. However, these bile acid sequestrants disrupt that process, causing the body to be unable to reabsorb those bile acids, producing a lower level of serum cholesterol, and hopefully decreasing the amount of bile acid deposits that occur when a patient is dealing with these biliary issues. If the person has no way of getting bile into their duodenum, so they have no way of providing for that need, in other words, they have a lithiasis somewhere, then these are contraindicated. These are for people who have a functional biliary system, but they are basically reabsorbing so much bile that it's being deposited out in the skin and causing itchy skin we call pruritus. It's mixed in water or fluid of choice. And it does have its own little fun side effects. The patient can become constipated. It disrupts the absorption of those vitamins there. And let's see, I think we're at Tonkwall. What do those 4 vitamins have in common?
They're fat soluble.
That's right. Those are the 4 fat-soluble vitamins. So when a patient is taking this, it disrupts their ability to find and absorb those within the chyme. And it does produce a risk of hypo or low prothrombonemia, meaning that that clotting factor is less, and as a result, they have an increased tendency to bleed. And then if they do have a infectious process, they may be placed on antibiotics. And then we mentioned that nausea and vomiting is common with all three of these problems, and so an antiemetic may also be necessary for these patients. Specific meds, no. Just recognize if there's anything that is an antiemetic on your blueprint, it may be the one that I have in your test questions. The same way with the antibiotics. Okay, as far as surgeries and procedures, lithotripsy I discussed out on the prep work, but basically the lithotripsy is using sound waves to basically shatter the cholelithiasis so that it can be passed in smaller pieces. The cholecystectomy, I talked about how that it can be done laparoscopically or it can be done as an open cholecystectomy. I talked about the benefits of both. Choledocostomy is the formation of an alternate pathway so that those persons who are passing stones or who are prone to develop them, we have a way to, in effect, bleed off, if you will, the extra bile before it causes more damage while the inflammation goes away. So choledocostomy is the T-tube that I talked about in the pre-class prep work. And then the ERCP I mentioned as well. And remember the ERCP, the surgeon takes it down through their GI tract, so it goes all the way through their esophagus, their stomach, down into the duodenum, finds that little opening, and then travels back retrograde towards the biliary system through that common bile duct. Okay, so what do we do for these people? Well, one of the things we want to do is all that routine pre-op and post-op care we talked about on Tuesday. So everything that was relevant back then pertains to these specific surgeries, particularly the cholecystectomies and the ERCP, for example. So we're going to do the head-to-toe assessment and establish baseline vital signs during that post-op time. Remember, we're going to do frequent vital signs, always comparing back to our pre-op baseline. We're going to address their nutritional needs, their fluid electrolyte needs. And so nutritionally, they may require a low-fat diet during that post-op time for the first few days until their body gets used to the fact that that bile is going to now flow continuously as opposed to intermittently. And gradually, what's recommended is that they gradually introduce foods, 1 or 2 items at a time, to see what they can tolerate. Because obviously some things have higher fat contents than other things, and it's going to require more bile in order to emulsify than other things. So with that being said, we're going to pause for just a moment. And you were supposed to bring some things to class that was high in fat. And so, let's see, I think I asked Tonko the last question, so how about Enid? Tell me some things that you brought to class that were high in fat content.
Avocado.
Avocado, so a natural fat, often viewed as a positive form of fat, if you will. What else?
Cheese stick.
Cheese stick, absolutely. Dairy is a source of fat, for sure. Delicious, but fat. Some almonds, yes. Any of the tree nuts as well as peanuts, again, have fat content that is both good for us and if consumed in excess could be problematic, but those are considered healthy fats. Okay? Anything else? What'd you say, French fries? Yeah, well, that's what I was going to ask you. I figured out of however many there are of you right now, 25 or however many is in Enid, I don't remember. If only 3 of you have something with fat there, I'm pretty sure the rest of you had it for lunch, okay? Because most of us eat something with fat content on a routine basis, especially if it's a quick or convenience type meal. All right, how about Stillwater? Let's go to Stillwater. What do we have on Stillwater campus?
Dark chocolate.
Dark chocolate. Ooh, some people like that. Not as fair, but that's okay. Anybody else? A cheese wonton. Yes, that so far has been a winning ticket. I'm wanting to know if she has plans for it in classes. Anybody else? Potato chips, peanuts, yes. Other things? Some almonds as well. Okay. That it? All right, let's go to Tom. Oh, she had a candy bar, but she ate it. Yeah, that's true. Yeah. And she hid the wrapper, so we wouldn't know the evidence, right? Okay, Tom Paul, what do you have?
Butter.
Butter, okay. Do you eat that by itself or with something else? Oh, yes, there's a judgment. No, that's only in simulation. Yeah. Well, I have to confess, my 11-year-old eats bread with his butter. Not butter with his bread. He eats bread with his butter. The only reason he has the bread is because he is required to. Okay? So, yes.
What about pistachios?
Yeah, some pistachios, you bet. Oh, I couldn't hear that one.
Pepperoni pizza.
Ooh, pepperoni pizza, yeah. That actually has the pepperoni and the cheese on it as well. And all the oil that they put on the crust that makes it so flavorful. Yeah. Okay, anything else? Okay.
Sausages and lots of pho.
Do what now?
Vienna sausages and lots of pho.
Vienna sausages, all right. For those of you who don't think that's real food, I apologize, but I haven't had them in years, but I used to eat them as a teenager and developed at least a sense of liking them. So, yeah. I'm never quite sure why they called them sausages though, but anyways. And whether or not they even came from Austria or wherever Vienna is, I don't know. But, okay, well, one of the things I wanted you to see with that exercise is most of us need what the biliary system does for us. Most of us would dramatically have a different diet if we should, even in theory, eliminate all the fats that we consume. It's not healthy because remember there are essential fatty acids we must get from the environment. Our body can't synthesize them. And they're necessary for your immune system, like Mr. Baird needs right now. Okay, so all of the things that you brought that have a fat content, since I don't know if they have essential fatty acids or not, just send them my way. I'll eat everything you offered and we'll see if I get better as a result. How's that sound? Yeah? Okay. All right, so let's move on with our nursing care. So during that post-op time, they may be NPO initially and then move to clear liquids. And so during that time, they usually will have IV fluids, may or may not need electrolyte supplementation. But if so, that will be tracked by their lab work and prescribed accordingly. Pain and discomforts, make sure that we're addressing that both preoperatively and postoperatively. And so because of the significance of the pain, it often requires an opioid as a means for comfort. And so we need to make sure that we understand just how painful this is. If you've ever smashed your thumb and felt like your thumb was about to blow up because it felt so swollen and so tight, imagine what that would feel like if that was your gallbladder feeling the same way, because it is basically the same process. It is edematous and swollen, just like your thumb is, as a result of the same inflammatory process. And it too is contained just like the skin that's holding your thumb. And the other discomfort is the nausea part. Don't let a person who's had any type of abdominal surgery suffer with retching and vomiting. That's just unkind. Okay, make sure we manage their tubes. So that the tubes that we're talking primarily about is if they do have an NG tube for that first 24 hours or the first 12 hours post-op, or if they have a T-tube, the choledochostomy, then we want to manage that according to the care that I put out on that handout. And I'm going to refer back to that here in a little bit if we still have time at the end of class. And then make sure that we're checking those dressings. Remember that even though a lap chole has been performed hundreds of thousands of times successfully, it's not without risks. There is a potential that a person can bleed on the inside, and because the incisions are so small, the dressing may or may not show up with any blood on it, but they could be hemorrhaging on the inside. So if anytime you see a change in that person's vital signs that are suggestive of number 4 that we looked at on Tuesday during the post-op vital signs, then be looking for a source. Be looking for a reason why those vital signs are going askew like that, okay? And then client and family teaching. Remember, if they do have a choledochostomy, they're going home with it. They're not going to be in the hospital long enough for us to take it out. And so they need to know how to manage it safely to prevent infection and to prevent complications from it. So they'll need that same handout of instructions that I provided for you. So see, there's your patient teaching handout that you can take with you when you leave our program. All right, so as I just mentioned, we're going to look for those complications. So we're going to look for hemorrhage or bile leaking into the tissues, causing pain and discomfort. So any kind of severe pain and tenderness in that right upper quadrant that is excessive in nature is probably not your typical post-op pain. There's something else going on. If you notice that their abdominal girth is increasing in size, and unfortunately that would be a late sign, because most of us can accommodate a great deal of volume before we begin to see noticeable changes outside. If there is any kind of bile or blood leaking from the wound, or you see it leaking in the JP drain, if they have a JP drain. If we see those trends in the vital signs, the drop in systolic and diastolic blood pressure with a corresponding increase in heart rate, and if we see indications of the fight or flight response, that restlessness, the agitation, the sense I gotta get out of here, something's not right, that almost sense of impending doom. All right, so client teaching, what are some of the things we need to teach them about? Well, we need to teach them about the very things that we're going to do for them. So in other words, we're going to teach them all the things during that pre-op time that they need to be doing during that post-op time. And then the post-op teaching has more to do with how to keep their dressings changed and their sites clean and when they can take a shower, those kinds of things. We're going to teach them about wound care, dressing changes, management of that T-tube. And then they need to know that if these things show up, they could be a problem that needs to be evaluated by their surgeon. So a fever and chills indicate what, Tom Law? Infection. Nausea and vomiting, although it may occur during the post-op time just due to anesthesia, after that post-op time, that pretty much should go away. So prolonged nausea and vomiting should be evaluated as possible infectious cause as well. Jaundice or dark-colored urine indicates that bilirubin is still being absorbed in high levels into the bloodstream, and we need to figure out why. Pale-colored stools means the bile is not entering the intestine, and it's not getting there and creating that brown color. That is our typical stool color. Feces that do not have bile present will be clay-colored, okay? And then pruritus. When the bilirubin begins to deposit salt crystals in the skin, it develops that itchy skin we call pruritus. So again, that should not be occurring during that post-op time. So what do we want to do to help minimize the risk of this happening to people? Well, first off, we want to try to help them learn how to manage their weight so that it is healthy weight for their height. We want to try to, across the board, eliminate obesity. We want to encourage them to eat a high fiber, high carbohydrate, high protein diet, as opposed to a high fat or high lipid diet. In fact, we want them to lower their intake of saturated fatty acids as well as trans fats. Remember, trans fats are those unnatural fats that were produced by the food industry to make things appeal to us. They tricked us and it worked, and now we suffer the consequence from it. Teach them to eat at regular times. Remember, prolonged fasting means the bile stays in the gallbladder for an extended period. And so those people who go on a 3-day fast or in order to lose weight, they eat whatever they want to most days of the month, and then 3 days out of the month they eat nothing, just drink water. Well, they may end up with gallstones during one of those episodes, and they don't need to. Teach them now how to participate in vigorous exercise. Remember, exercise has numerous benefits to all of our body systems. Management of care. So this is that delegation component. Okay, so what are we going to pass off to other members of the team? Well, so one of the things we can delegate are any objective data collection that the individual has been trained to obtain. So vital signs, recording of INO, or the patient's weight. And then collaborate means we're going to work with other members of the team. So we're going to work in cooperation with the primary care provider and a dietitian, both during the pre and post-op time, depending on the nature of the patient's concern. Okay. And then just recognize that some cultures have diets, those comfort foods that are high in saturated fats and cholesterol, making them at risk for not only cardiovascular concerns, but at risk for other issues as well. Okay? So I'm going to switch over to that guidelines for care of the client with a T-tube. And during the last few minutes before we take a break, we're going to look through that right quick together. And that way I can answer questions concerning that, since I really didn't get to deal with that on the prep work for very long. Okay, so remember that the choledostomy is put in place as a way for us to siphon off bile that the liver is producing but cannot flow through the bile duct down into the duodenum due to inflammation or intermittent obstruction. Okay, so maybe there's a stricture that hasn't been corrected surgically. And so it allows a collection bag, a system to be able to bleed that off. That drainage system should always be kept below the level of the gallbladder. We don't want anything flowing back into the person's body once it's outside it into the system. They need to know to observe the amount of drainage, the color and the consistency of that drainage. And then they need to understand that there's going to be the greatest volume is going to be in that first 24 hours, and it should decrease to about half of that volume or less over the next 3 to 4 days. If it ever goes the other direction, then it means an obstruction has occurred and it needs to be revisited. Okay, so when it shows anything in excess of those expected amounts of output. Okay. If there's any kind of strange odor, if they begin to see pus or purulent drainage, they need to let the doctor know as well. They need to watch for inflammation around the portal entry, okay, because it too can become inflamed or infected, or if bile is leaking around the tube, it can irritate the skin and begin to break down the fats in the skin itself. They need to know how to change their dressing and keep it clean. They also need to know that they can't inject anything into that T-tube, and nurses can't either unless we have a surgeon's order. And then making sure that the tubings are not kinked. And when they do consume a meal, we want them to know how to clamp off the T-tube so the bile can enter the duodenum when it's needed. And so we can see how they process and tolerate that. And then make sure that they're watching for that return of normal color, which means the bile is going the right direction. And it means that that edema of that common bile duct has resolved and the T-tube is probably ready to be removed. Okay? All right. Any questions over anything gallbladder? Or pre and post-op? I guess I could answer those too, but we're gonna have a study session here in a little while, so. Okay, then let's take a few minutes break, so 1:30, and then Mrs. Martinez will be back and we'll do the next part of your lecture.